programme just a tiny bit now and ask John Klein to present on a very difficult subject to us, jobbing cardiologists, which is the question of culture-negative endocarditis and how to do it properly.
Right, thanks, John. So I'm a microbiologist. I also got my foot in the pathology camp, but I also go and see live patients on the wards. So I'm going to talk about this subject of what I would call blood culture negative endocarditis, which is someone that's interested in endocarditis is, you know, a fascinating part of managing these patients, because if you think endocarditis is difficult, these are really difficult. So I'm going to just touch a little bit on what evidence there is, which is actually very little. It is pretty well evidence-free how you manage these patients. I'm going to talk a little bit about diagnostics, but Jonathan Sandow is going to be talking later in more detail, so I'll skirt over some of the diagnostic details and try and give you a little bit of a clinical approach to these patients. So it's quite a personal view, I would say, and not necessarily something that's enshrined in evidence or endorsed entirely by guidelines, which actually give you very little guidance how to manage these patients if you read the recent guidelines. As we know, endocarditis is usually caused by bacteria and occasionally fungi, and it's an endovascular infection. So not surprisingly, usually got them in the blood and you can detect them. So what I'm going to talk about is blood culture negative endocarditis, and I will just define the different ways, but I would essentially say this is someone who has endocarditis, infective endocarditis, but by the end of a normal incubation, 5 to 7 days usually, of the blood, you can't grow anything. So most of the patients, one of the key things is whether the patients had any recent antibiotics, and actually in series, at least half of them, that's the reason you can't grow anything, is because of antibiotics. If they'd not had recent antibiotics, then they get our sort of diagnostic antenna going a bit faster, because we're starting to think about odd organisms, including things that are slow to grow. So the hat-check groups, a group of little gram-negative organisms, grow slower than usual bacteria, and some which are, well, nigh on impossible to grow, like Barts and the agent of Q fever. And not forgetting that not all these patients have endocarditis. Of course, that's the challenge. There's nothing in the blood, then usually the diagnosis isn't secure, actually. So why is it a problem? Well, as you know, blood cultures are our major criteria in the Duke diagnostic algorithm. So you usually got someone with either possible endocarditis or not endocarditis who you're seeing, actually, if you start punching in the Duke criteria. So there's diagnostic delay. You're trying to work out what's going on. And of course there may be therapeutic delay, perhaps appropriately in terms of antibiotics being started, because you know what you're treating and the patient's stable. Delay is sometimes the right thing. But clearly if someone does have an infection, you want to get them on treatment, the right treatments, as soon as possible. So no bug. It's obviously tricky to get the right antibiotics. There's a tendency to overcomplicate regimens, I think, and cause side effects. So I think people who are not so expert in this sort of situation will tend to throw too many antibiotics. It's a bit of a personal view. I see people coming from DGHs on 3 or 4 antibiotics sometimes, usually with kidney injury and a whole lot of other problems. And actually the trick is to try to keep it as simple as possible and not to fit around the antibiotics too much. Make a decision about what you think the right regimen is and carry on unless there's a definite reason to switch. But surgery is the other thing. What do you do about surgical timing in culture-negative endocarditis? It's even more difficult, I think, than the ones you know where the organism is. If you know what the bug is, you're on the right treatment because you know what the organism is, it's a bit easier, isn't it? Because you get to 1 week, 2 weeks, they're not doing really well, still got a fever, you're sort of thinking about surgery. But if it's blood culture negative, you know what you're treating, you're also thinking, am I on the right antibiotic? So it makes the whole decision-making around surgery really tricky as well. So lots of challenges. So just talking a little bit about, if you like, derived from series, which there are obviously in the literature, about what causes blood culture negative endocarditis. So the bottom line actually is that if you've had recent antibiotics and you can't grow anything in the blood and someone has infective endocarditis, then it's usually caused by the usual suspects. So it's less likely to be the fastidious exotica in the long list of causes of endocarditis. And streptococci would be up at the top, I would say. And actually staph and enterococci would be quite a lot lower down because they're basically a bit tougher and quite hard to sort of sterilised blood cultures with a bit of amoxicillin from the GP. So the dominant group, I would say, is streps. And those without recent antibiotics, then we're starting to think about these, more exotic things. So the hatchet group I mentioned, fungi, and people talk about fungi as one organism, actually it's a whole range of different organisms. And actually, Aspergillus is by far the most important in blood culture negative endocarditis, because Candida grows quite nicely in blood cultures, actually. Bartonella and Coxiella, which I'll talk about later, are big players, actually. It will be variable, the percentage caused by these two agents, but it's very clear from recent series, mainly derived from France, who has a monstrous series on this condition, where, they might cause up to half of blood culture negative might be caused by Q fever or Bartonella. So hence those two, diagnosed mainly by serology, we would think quite early in this setting of nothing in the blood, no recent antibiotics, testing for these. Whipple's disease, actually I've been a consultant since almost 12 years and I do all the endocarditis work, so I've seen hundreds of cases. I've never seen a case. I think Amanda over there has seen one. It definitely exists, and interestingly they don't present like some of Whipple's apparently, joints and fevers and middle-aged men. They present like culture negative endocarditis, so it's one of those things you can't spot, I think, clinically. You just have to do the tests, which is mainly PCR on the valve. And then, of course, a long list of odd things that grow slowly, you can't grow very well. But the important thing is to remember the Bartonella and the Coxiella are the key extra tests, I think, to think about prior to surgery. So this is an oldish paper from my predecessor I was involved in. That's my institution, obviously. So 75 to 2000, so quite an old series now. But 12% of the 500 cases were blood culture negative in our series. And of the 32% pathologically proven cases, only 11 of the 34 were definite by modified Duke criteria. So it makes the point about diagnosing this condition is difficult. What about the etiology? About half of them, no organism was identified. And it would be a current series, I did it my recent 5 years, it'd be less than that because we do PCR on the valves regularly. But there, you can see some we don't find out what it is, and even now we still come across cases like this, even with heart surgery. 10 of them, so quite a big chunk, gram-positive cocci, streps, staphs, and enterococci. And you see even St Thomas's, it's not a hotbed for Q fever, I don't think. We had 8 cases of Q fever and 6 of Bartonella and 4 fungi. 2 of them Aspergillus. Interesting, one of them is histoplasma. So there's always a new bug to put on the list for endocarditis. So that's published in Heart 2003. So a little bit about diagnostics again. So this is the largest series from the French group down in Marseille, that's just almost, you could say, obsessed by culture negative endocarditis, in particular Q fever and Bartonella. So 759 cases of endocarditis. So it's a referral centre across France. Causes of organism 2/3 here. Half of them made by serology, Q fever and Bartonella. So take away anything from this, it's if you've got nothing in the blood, particularly in the recent antibiotics, you really just need to do those 2 tests, even if there's no particular clues to those being the cause. 14% were by PCR only, and notice that 106 of them were PCR on the valve, only 3 on the blood. So I'm sure Jonathan will talk about PCR on the blood. I'm not a big fan of PCR of blood. Certainly the broad range PCR because it's insensitive. Actually, a blood culture is a pretty sensitive test because you might have 2 colonies in the blood. It's like a PCR, a biological PCR by growing up bacteria. So the yield of PCR in the blood is very low. But if you come to surgery, there's a very high hit rate. There's other fancy techniques that the French use called cell culture, which doesn't give you much beyond PCR, actually. Interestingly, there are no viruses. I suppose that's not a surprise. But interestingly, no chlamydia, which in the old literature was quite an important cause. Probably most of them were cross-reactive serology of Bartonella. No mycoplasma pneumonia and no brucella. So it kind of makes the point. You don't need to 10 serological tests, or I certainly don't think you do. You need to do Q fever and Bartonella, and the others really only if there's some epidemiological clue, I would say. I think it's just unnecessary to do extensive serological testing in this setting. So what about the clinical approach? So obviously you're thinking, have they got infective endocarditis? And obviously all the usual clinical signs and symptoms you're looking for, and obviously the echocardiography, which is obviously in blood culture negative, is particularly important, isn't it? Because it's the other major Duke criterion. So you need clearly an expert cardiologist, and one thing I've learned is the importance of having a cardiologist with a particular interest in endocarditis and valve disease, because as you all know, this audience, you'll have an echo, and two different cardiologists will give a different report on what it means. And that's what I've learned about working at St Thomas's in a team. You want to know if they've had antibiotics recently. Really important question. And have they taken it, particularly in the last few weeks? When, which, and for how long? And interestingly, sometimes you get some clues from whether it made them any better. So if someone said, yeah, I got amoxicillin 4 weeks ago from my GP and the fevers all went away, and then they came back, I mean, that gives us a bit of a clue. It's something that's going to be penicillin susceptible. So occasionally you can get little clues from antibiotic use and clinical response. Think about also antibody screens. A rheumatoid factor is actually a minor criterion. In other words, you quite often get some also antibody production endocarditis, but of course it could also be a manifestation, something like Liebman-Sachs and antiphospholipid. So it may be useful for two reasons to do an autoantibody screen. If there's a strong suspicion of endocarditis, sometimes you might be able to stop antibiotics and reculture and take more blood cultures. In my experience is that it's rarely the right thing to do, and if it appears to be the right thing to do, it rarely gives you the organism. If someone's had more than a few days of intravenous antibiotics, it's probably not going to be worthwhile at all, because most of the organisms that we're talking about here in culture negative, as I say, streptococci, if you give 5 days of carmoxyclav IV, you won't grow those streps again probably at least a month. So you can't just say, stop, do blood culture the next few days and think you're just going to magic up bacteria in the blood. So it's understanding those things quite important. So sometimes if you've had quite a lot of antibiotic very recently and you've got a possible diagnosis, you just have to make a decision. What am I going to give them? I think they've got endocarditis. I'm not going to get an organism in the blood culture, and crack on with something. So what about clinical clues? So there are a few things that might help, and I say that because you can't put huge weight on these things, but as I say, what about a bit of amoxicillin that almost cured the patient? I think that tells you quite a lot. Poor dental health, it's quite common anyway, but it does make you think obviously about streptococci and other related organisms. I think the renal group and vascular access devices and certainly pacemakers makes you think about staphylococci, prosthetic valves, and drug users, fungi. One group that really frightens me is the sort of early prosthetic endocarditis and there's nothing in the bloodstream. Because it makes me think about aspergillus in particular, and that is an absolutely devastating condition. Even if you start the right stuff, it's still not going to make the patient better. I don't like culture negative early prosthetic disease. It's a fearful scenario. Alcoholism and homelessness associated with Bartonella, as is cats, particularly one of the species. So that can be useful. So if you've got an alcoholic, homeless guy, culture negative endocarditis, I'd be quite hot on thinking about Bartonella. And then maybe foreign travel, unpasteurised milk, animal contact for brucella, which, by the way, doesn't exist in this country, so there's no point doing brucella serology in the UK if they haven't travelled anywhere. And Q fever, which does exist in this country. Diagnostic approach, just one slide about some of the tests, because Jonathan will go more into this, I think. So serology, if I said before, most of the time you should do these tests. The problem is, by the way, in case you don't know, the UK cannot perform Bartonella serology as of last year, or this year I think it was. They just stopped doing it, so they have to send it to France, can you believe it? So anyway, it is the world centre probably for Bartonella serological testing, so it's a bit of a pain, but we have to ship stuff down to Marseille. Q fever can be done locally, I'm pleased to say. The beauty of these serological tests in someone with a long history is consistent with this diagnosis is they're very sensitive and specific if you know how to kind of interpret them. Very useful. So other serological tests, I say, should be very selective. PCR on whole blood, it's just got a very low yield. The only situation I think where you may be worth considering is specific PCR for certain organisms, like the Whipple's bacillus. But the sort of broad range PCR has a very low hit rate. It's probably just not worthwhile. Now, valve material is exceptionally useful. Now, we don't encourage surgeons to operate just because I want to know what the organism is. But that is part of the decision making, I think, when you're thinking about surgery and difficult culture negative cases. You are very likely to get the organism if you operate because the valve tissue is usually packed with organisms. Even if they don't grow, you can see them on the gram. Or the 16S type PCR looking for broad range PCR, it's got a high hit rate for picking up the organism. So it is diagnostically useful, although obviously it's not the only reason why you operate on your patients. And I mentioned about sensitivity results. So obviously you can't grow them, but Actually, one thing microbiologists are pretty good at, if you get a name of an organism, they'll have a pretty good feel for what antibiotics are right for that organism, even if you haven't got a sensitivity, and that's what our training gives us, I suppose. And histology, we heard a bit about histology. I mean, I've sort of actually rather on and off sent valves to histology and culture negative, and I've decided that I should do it all the time actually now. So I don't know what everyone else thinks, but I think if you read literature on this condition, they'll say histology should be routine in blood culture negative. I think it probably should. Occasionally, as you'll see one of my cases actually, it can give you some quite wacky diagnoses and just steer you a bit towards the diagnosis. Or indeed tell you that it isn't endocarditis, and we had a case like that recently. So, empirical antibiotics. Everyone wants to know what I should give my patient with endocarditis. And these are quite difficult decisions. I mean, very difficult. For my registrars, what I say is, in my induction, I said, blood culture endocarditis, talk to your consultant. There's no guideline that says what you should give. I think it's just very complex, and that's why you employ consultants, seems to me, rather than just writing down a big list of things you should do. The guidelines that are there, I had another read through them last night. There's just lots of text, and could try this, could try that. They're all very different. There's no clear guidance except to say infectious diseases consultation recommended, which I think is probably right. It's just something you need someone who's experienced in this condition to weigh up everything and come up with a sensible regimen. Some common errors, it's just personal views of the way things happen when patients come over to us. There's an over-reliance on Vanc and Gent, plus minus rifampicin. It's a sort of, don't know what's going on sort of regimen, isn't it? But it's not necessarily appropriate to use glycopeptides up front in this setting. Kidney injury is very common in the elderly who get vancomycin and gentamicin. It's shocking really how we can poison our patients sometimes. Treatment of suspected pacemaker or ICD endocarditis as prosthetic valve. I don't think that's necessary because you're going to remove it, so it's relatively straightforward. If you're just going to take the thing out, you don't need to give them 3 or 4 antibiotics. You just probably need to give them 1, and I would usually give vancomycin as the mainstay backbone in this setting. Unchallenging penicillin allergy history, it's just believing the allergy history. Maybe it's not an allergy. Maybe you can give them ceftriaxone, which is safe in the vast majority of people who are penicillin allergic. We're lucky in St Thomas's that we can actually test people for penicillin allergy as an inpatient. And I do that regularly, several times a year. And most people who think that penicillin allergic aren't, of course. So it's a very useful thing, but I realise that many hospitals don't have that facility. But if you are a centre for endocarditis, I think you should be asking for it, because I think it's a really useful thing in a tertiary centre. Try to avoid multiple changes of antibiotics, because it just causes confusion. And failure to consider surgery, of course, that's often an error, isn't it? And I think in non-expert hands, it's just to keep filling with antibiotics and not consider the surgical side, which this audience will know is absolutely key from the beginning of endocarditis to always be thinking about surgery. When is it right to do it? Is it right to do it? And if so, when? Which is obviously one of the most, I think, one of the fascinating and difficult decisions in this condition. And of course, if you operate, you can remove the focus. That's got to be a good thing, isn't it, for infection? And of course, establish the etiology. So what should I give? I've been waffling about saying you've got to be an expert and decide the expert what to do. But I'm just going to give some personal takes on how I would approach antibiotic decision making. So you've got a subacute type history over a week, native valve or late prosthetic valve. Another mistake people make is think all prosthetic valve endocarditis must get vancomycin in the regimen. Especially if recent antibiotics, then it's likely to be streptococcal, and you can use a regimen like amoxicillin and gentamicin. Treats the streps, doesn't it? Treats the enterococci, has pretty good activity against the Hatchet group as well. You can also use a ceftriaxone-based regimen. I do this where I'm not, and the main difference we know is you're not treating enterococci. So I think you can make a judgment whether that you're worried about enterococci with a bit of experience. It's very unusual in children to get enterococcal endocarditis, and it's quite difficult to sterilise the blood with enterococcal endocarditis because they're quite tough to kill, unlike streps. So in the younger patients, children and younger adults, congenital heart disease, for instance, I would sometimes go for a ceftriaxone-based regimen. I'm also thinking ahead a bit because OPAT is an option sometimes in these patients, and outpatient antibiotics, there's not many things you can administer via OPAT, parenteral antibiotics in the community, and ceftriaxone, well, it's the commonest one that we use in OPAT clinics. And then Barts and Q fever serology. So ideally, I want to get those quickly. But I, knowing where to send it and what to do, have trouble getting quick results, and I suppose that's the challenge here. But always think about Barts and acute fever, really important. In the acute history, it's a bit different, isn't it? And the real reason it's different, of course, is Staph aureus, isn't it? Because the top regimens aren't particularly focused on Staph aureus. So in this setting, they're not usually culture negative. That's the first thing to say. Most acute endocarditis is not culture negative because you come in ill, febrile, and you have a blood culture. But if someone doesn't get a blood culture in before they slap me on the comoxiclav, tazocin, or ceftriaxone, or whatever your favoured antibiotic is, then you might have a negative blood culture and still have acute endocarditis. And essentially, you're treating Staph aureus here in particular. So big doses of flucloxacillin plus or minus gent. And in a prosthetic valve scenario, I think you've got to cover in acute setting for all staphylococci with a vancomycin-based regimen. And then cardiac devices, I don't personally think most of these are actually quite indolent, first thing to say, unless they're Staph aureus, and actually it's usually quite obvious they're in blood culture. So it's not that common to get a sort of acute culture negative device-related one. But if there is a sort of more subacute, haven't grown anything, then 90% plus organisms are gram-positive in device. So vancomycin alone, I think, is adequate. And of course, if you've got endocarditis affecting a cardiac device, it needs to be removed. And that makes actually life, of course, a bit easier for us because you're taking it out, so you don't have to worry so much. A few more thoughts. Close communication is very important with the team, of course. Try not to choose a regimen that's just not going to be tolerated, particularly over a period of weeks. Vanc and gent for 6 weeks for someone with prosthetic valve endocarditis who's 75 years old is not really likely to be a goer. So you want to try and avoid those sort of decisions. Where possible, use beta-lactams rather than glycopeptides. And if you can, penicillin allergy test, great. Remember the ceftriaxone can be used in penicillin allergy with a bit of caution. Empirical treatment for Q and Bartonella, I very rarely do that. I think you do need to get the test done quickly, but they are quite chronic infections, so you usually got a bit of time. But just sending them off and hoping you're going to get the result doesn't work very well. So as a microbiologist, I put the pressure on, press the buttons to try and make these things happen if I really want to get these results. Empirical treatment for fungi is rarely needed. At the end of the day, I suppose I'm really talking about Aspergillus here. Aspergillus is very high mortality disease, often on prosthetic valves, and essentially they need surgery. And the diagnosis is often made at surgery, of course. It's a horrible scenario, and they don't do very well, as you know, whatever you do. But I don't think just flinging antifungals at them is really the right thing. If you really think someone's got, like to have a fungal endocarditis, you probably need to get on to the surgery. And around the time of doing the surgery, you're going to start slapping on the antifungal treatment at that stage. So I've got a couple of cases. Can I just flip through a couple of cases? 50 all from the last year or so, actually. 51-year-old with an implant, put in for VT, non-sustained VT. He came in with an amazingly long history of malaise, intermittent rigors, and breathless for over 12 months. His GP treated him twice for Lyme disease because he'd been to the USA, or in fact his symptoms started before he went to the US. All he had was one splinter hemorrhage, we all know that means nothing, and a bit of a fever on and off, and the CRP is slightly raised. But he had a transthoracic echo, showed a large mass on the lead. He also had a CTPA showing lots of infarcts. So the diagnosis was quite secure. This is quite an easy one in a sense. No organism in the blood, obviously, because it takes the title of the talk, but the diagnosis, he had to have endocarditis, didn't he? So 4 blood cultures were negative, taken prior to antibiotics, kept up for 5 days, what most people do as a routine. Treated Vanc, Gent and Riff and got better. When it came to us, I thought, well, I think he's got endocarditis. I don't think it's gram-negative. We're going to take the device out. I don't think he needs gentamicin and rifampicin. So we rationalised it right down to vancomycin. Took the thing out, and actually we saw on the gram of material attached to the lead organisms consistent with Propionibacterium, which is a little gram-positive rod that lives on your skin, and it was detected by 16S as well, and we changed actually to ceftriaxone and completed 6 weeks. Probably can't see that. See that little wiggly thing in the middle there? So that's a curvy gram-positive rod, which is actually all those wiggly things are all the organism. So actually the gram stain of a valve or a bit of tissue is quite powerful actually in good hands. In other words, there's usually a lot of organism there. So I looked at this myself, I thought there's got to be something there. And sure enough, heaving with gram-positive rods. Another one, a very young girl, with a 10-day history, so over the week, so probably not Staph aureus, but a bit septic, quite shut down, murmur of quite severe AR noted, high white count CRP, bicuspid aortic valve, so obviously a congenital condition, with the vegetation severe AR. One blood culture was taken. This is in paediatrics now. What happens in paediatrics? You'll probably get one blood culture and then you'll be on ceftriaxone. But that's okay, because, I mean, you can't really expect to suspect endocarditis in a 1-year-old with no history. So given ceftriaxone, gent, and vanc, so perhaps a bit over the top on the antibiotics, but did the deed. Aortic valve repair. I've never heard about until I did that. So they repaired it rather than replaced it at day 3 of life. And on the microbiology, we couldn't see anything on the gram. Culture was negative. And we sent the Great Ormond Street for 16S and identified King-Ella-Kingi, the DNA of. So one of the K of the hat check group. So a little gram-negative rod that doesn't grow very well, takes a long time, so it didn't grow in the single blood culture was taken. If this child had several blood cultures and kept them up a bit longer, you might well have grown it. And we rationalised ceftriaxone. And just one more, if you wouldn't mind, because it's probably the quite most interesting one recently. 74-year-old, long history of night sweats, bit of weight loss, bit of anorexia, some breathlessness. 8 months before she was diagnosed with polymyalgia rheumatica by a GP, treated with steroids, got better a few weeks, and then they stopped steroids, and there she was. She had lots of antibiotic courses. This is a very typical case, Comox, doxycycline, very recently finished, so you're thinking, we're never going to grow anything. Given 1 dose of Comox, Clav-A&E. She's got no stigmata of endocarditis, which of course is quite common these days in this condition. Either had got infection, severe AR, and negative blood cultures. Barton and Q were sent. Started antibiotics because I thought she could have endocarditis, and was heading for surgery, I knew, so I knew we were going to get a valve. Well, I thought we were going to get a valve. Interestingly, she didn't get any better, and that's sometimes a clue in culture negative endocarditis that's not endocarditis, is there's just absolutely no response at all to antibiotics. It should make you think, is it morantic, non-bacterial? And then she had an AVR, and the surgeon said the ascending aorta looked very thin, paper thin, kind of very abnormal. Didn't look like endocarditis. The valve wasn't sent to microbiology, which I duly told them off for. No uncertain terms. He was very meek and said, oh, I should have sent it, But I did send a bit of the aorta for histology. And actually, probably Kim will know much better what this shows. But, so this is the aorta, which is that rather thin? Which shows quite a lot of necrosis and inflammation. And that's a giant cell, isn't it? Yeah. So actually, this was a giant cell aortitis. So then we put it all together. So yeah, she had polymyalgia rheumatica, she's got giant cell aortitis, she's probably got one condition and no infection at all. So that was her diagnosis, made of a non-infectious cause of a syndrome that looks a bit like endocarditis. And I'll leave it with the conclusion. I'll stop there.
Okay, brilliant. Thank you very much, John. Maybe we've got time for a brief question, a short question, if there is one. Any? Oh yes, so question.
Where's the phone? It's not uncommon that we see fibrin materials.
John,
sorry. Yeah, sorry. It's not uncommon that we see fibrin materials on device leads. So there's just fibrin material on vegetation. So for the first case you showed us, if the patient did not have evidence of septic emboli, would the management have been taken?
Yeah. So what you're saying is, if you do an echo someone with a lead in their heart, then you might see things flopping around on it. Yeah, absolutely. So it's a clinical scenario always is the important thing. Although his history was incredibly indolent, it was very suggestive actually you took the history of this guy. He had episodes of quite good going rigors every sort of few weeks, and he just felt extremely tired all the time. So there's something going on. So you're right, it's not just the echo, it's the whole picture. He also had quite a large mass, I think. I think size probably matters. A big chunky thing on the end of the lead is probably needs a bit more than a little thing flapping around. And as you say, he had the emboli in his lungs as well. So clinically, I think it was a relatively easy one, so this must be infection. And then, of course, the decision to remove the device becomes easy, because we all know that pacemaker endocarditis needs extraction. And then, of course, I was quite like to get the organism there, and indeed, we did find the bug in the end.
Rachel, you had a question.
John, thank you for your talk. Obviously, question. Thinking out of the box about other conditions that masquerades and device, I've seen a couple of cases over the decade of patients with B-cell lymphoma, and they can come in with good features, particularly on prosthetic valve, and also complaints in
Yeah, Jonathan might talk a bit about PET. I didn't put anything in there, but I have a little bit of experience in the sense I've done it a few times. I think the literature suggests it's pretty good for prosthetic valve endocarditis. I think that there's not much evidence to suggest it's particularly good for a lead-related endocarditis. I think it's quite good for box infections, generator site infections. Difficult ones, I sometimes think it's a pretty good thing to do. I have certainly seen cases of definite endocarditis with negative PET. So, yeah, I don't think it's very good as a routine test at all, but I think it might have a role in very selective cases. I mean, interesting, in the European guideline, it's become a major dupe criterion. I don't know where they plucked that out from. I'm not sure it's quite got the attributes to be a test that's the same as, you know, a vegetation or a major criterion by blood cultures. But so I think it's got, at the moment, from the evidence, it has a role in selected cases, but not as a routine, I think.
Okay, great.